Okay, this is going to be a short little lecture on the differential diagnosis for muscle weakness and a short bit about how the neuromuscular junction works. And this is just a little picture of how I felt while I was researching this topic. According to Up to Date, the way that you want to diagnose muscle weakness, you do it in 3 steps. So the first step is you want to make sure that it's not an asthenia, and I don't know if I'm pronouncing that right, but basically it's not true muscle weakness. So it's stuff like, is there pain? So pain can cause a sense where people say I'm weak, but really when they try to move it's causing pain, or they could be fatigued, or something that's not a true weakness. And so you have to differentiate that from a true muscle weakness. One of the big clues is typically whenever a patient has asthenia, they will complain of being weak. Whenever a person has a true muscle weakness, they will have a concern or a complaint of not being able to perform a specific task. So remember, performing a task such as walking up the stairs or combing your hair. Once you've identified that it's a true muscle weakness, the next 2 things you want to do is localize the lesion, and then from localizing the lesion, you've narrowed down your list of possibilities extensively, and then you can determine the cause of the lesion. And so I'm just going to expand on these 2 things over the next many slides. In general, you're going to have 4 categories of areas where lesions occur. You're going to have the upper motor neurons, the anterior horn, the peripheral nerves, and the neuromuscular junction, and then the muscle itself. And then the specific categories or types of disease states can be, of course, the general Vindicate would work well here, but you got genetic, inflammatory, infection, neoplastic, toxin or drug, and then metabolic or endocrine. This chart is nowhere near exhaustive. It's just giving you specific examples or the more common examples of things that fit into each category. This chart was taken from Up to Date. It's going to be on my study guide, so you can go ahead and download it if you want to keep that. But the general things you want to check are the distribution of the weakness, the deep tendon reflexes, Babinski's sign, and sensory defects. So that's what we have here. Each type of lesion will have a specific pattern or distribution, whether it's distal, proximal, whether it affects specific asymmetrical or symmetrical, those kind of things are what you're looking for whenever you're talking about distribution. In general, upper motor neuron lesions will cause hyperreflexia. Lower motor neuron lesions will cause areflexia or reduced reflexes. Upper motor neuron lesions are usually going to have a positive Babinski's sign. We'll talk about why that is in a little bit. And then sensory deficits with peripheral neuropathies, which tend to be lower motor neuron lesions. Peripheral neuropathies usually have both motor and sensory. If you have something like asymmetric weakness, that's going to typically be within the CNS. Things like stroke can cause that. If, on the other hand, it's symmetric, then you divide that into, is it distal or is it proximal, and then you look at the distribution of that as well. With distal, some big categories: early motor neuron or peripheral neuropathy. With proximal, you look at myopathies, muscular dystrophies, and myasthenia gravis. We'll go over all of these and talk about the pathophysiology in a moment. If you're an algorithm person, this algorithm is generally going to be helpful. So you've identified that there is an objective muscle weakness rather than someone's fatigued or in pain. And if there are if it's not a true weakness, then here's a list of possibilities. If it is a true weakness, then you come over here and you say, is it general or is it localized? From there, asymmetric or symmetric, and then distal, proximal, or specific pattern. Before I get too much further in discussing upper and motor neuron lesions, I think it's a good idea to take a quick step back and ask, what is upper motor neuron, what is lower motor neuron, and how do they play a part in all this? So what I want to do is take a look here. This is a free image from Wikipedia. Upper motor neurons are defined as neurons that have their origin either in the motor area of the central nervous system, or in some cases they can have their origin in the brainstem. A lower motor neuron, on the other hand, would be the nuclei of the cranial nerves, or any nerve that has its nuclei in the anterior horn of the spinal cord. Upper motor neurons will start up here with their nerve body, send their axons down, and synapse on to the lower motor neurons, which will then go out to the muscle. The lower motor neurons may also have some input from other places as well, such as the reflex arcs, the interneurons and such. Now with that understanding, let's go ahead and take a look at some upper motor neuron lesions. So what are the characteristics? The characteristics, you're going to have muscle weakness. So muscle weakness, that's everything we're talking about right now is going to have muscle weakness. That's the main thing we're looking for a differential on. But also slowness and spasticity. And so what happens is, at the very initial part of the upper motor neuron lesion, you get flaccid muscle or very weak muscle without spasticity. But then as a short time progresses, you get the spasticity. And that is caused by the removal of inhibitory influences from the cortex. So the nerve synapses from upper motor neuron and elsewhere will travel down from the brain and synapse onto the lower motor neuron, and they can give either excitatory or inhibitory potentials. Whenever the inhibitory stimulation is gone, the lower motor neurons may fire more readily, and they are also more subject to input from the interneurons in the reflex arc. Sort of the same thing with Babinski's. So when you're a young child, you have a positive Babinski sign because all of the inhibitory firing isn't completely done and going as it should be until you're a certain age. And then after everything is completely developed in the nervous system, the Babinski sign will be absent. However, whenever you take away the inhibitory input from the central nervous system, then the Babinski sign will return. That's also for the same reason that you'll get an increase in deep tendon reflexes. So increase in deep tendon reflexes are indicative of upper motor neuron lesion because you're not getting the inhibitory commands from the central nervous system. And hyporeflexia in superficial reflex. So what does that mean? Superficial reflex is like somebody scratch your stomach or rubs on your skin in a certain way. So with one of the main superficial reflexes, the abdominal reflex, like I was saying, and you're basically taking a blunt object, scratching around the belly button, or the umbilicus, whatever you want to call it, and you'll watch, and typically that will cause the abdominal muscles to contract. And for unknown reasons, an upper motor neuron lesion will cause that to diminish significantly. Also with guys, there's the cremaster reflex, which is another superficial reflex. A short list of causes of upper motor neuron lesions. You have a stroke. I'm not sure what space occupying the CNS is. That I haven't looked into yet. You can have lesions of the spinal cord from trauma, infection, tumor, vascular degeneration. So then also with degenerative skeletal changes, like if you have spondylolithiasis in the spine and it causes damage, then demyelinating diseases and leukodystrophies. Then lower motor neuron, if you understand the upper motor neurons, lower motor neurons should be easy. You get a paralysis and weakness, so weak muscles, that's what this whole thing's about. You get areflexia because if you have, this is the lower motor neuron, it's going to the muscle fiber. Here's my muscle right here. And if I have a lesion right here and this reflex arc is coming in, that input from the reflex arc is not going to be able to travel down this tract and get to the muscle fiber. So it's going to have areflexia, you're going to have fibrillations and fasciculations. Now these two things are twitches in muscle fibers. With fibrillation, what happens whenever you denervate the muscle, it changes the excitability of the muscle. So change of excitability, it causes it to be slightly more excitable whenever you take away any type of input to it. So lower motor neurons are the ones that go into the muscle, and you take that away and it changes the muscle's excitability. Fasciculations are due to changes in the alpha, changes in abnormal activity, so abnormal activity of alpha motor neurons. So if this neuron has some type of lesion in it, but it's still like it's going crazy and just randomly firing off an action potential for no good reason, that would be a cause of a fasciculation. So that's the difference between the two. Basically, you're going to get a similar result. Quickly, an example of a lower motor neuron lesion would be a myotropic lateral sclerosis. Lower motor neuron lesions are classified as peripheral neuropathy. Now you're going to see that not all of these are in the peripheral nervous system. Specifically, radiculopathies are lesions inside the anterior horn. So any lesion in the anterior horn of the spinal cord will act as a radiculopathy. And you know from anatomy that the spinal cord itself with the brain is considered the central nervous system, not the peripheral nervous system. But these are still called peripheral neuropathies because they deal with lower motor neurons. So go figure. Now, polyneuropathy has one big clue or indicator is that it affects distal muscle groups more than proximal. So one of the main causes of polyneuropathy is diabetes, and so you get what's called the sock and glove effect, the sock and glove syndrome with polyneuropathies, and that's where you get possibly sensory deficits and muscle deficits in the lower legs and feet and the lower arms and hands. It's important to know a polyneuropathy is not a problem with a specific nerve or a specific neuron. It can be a sensory, or it can be a motor, or it can be both. So with peripheral neuropathy, it's important to note that it can be sensory, it can be motor, or it can be both. One of the patterns you want to look at with peripheral neuropathies is the sensory, motor, or both pattern. So if it's both, you want to say, is sensory greater than motor, or is motor greater than sensory? And that's another pattern you want to look at to help you identify the cause of the lesion. With mononeuropathy, it's just a problem with a single nerve. And so you look at dermatomes and myotomes. For example, if you have carpal tunnel, that is a mononeuropathy. Now, a special type of mononeuropathy is mononeuropathy multiplex, and that can kind of look like polyneuropathy, so you got to be careful. And what that is, it's a simultaneous mononeuropathy in non-contiguous nerve trunks. So let's look at a few of the different radiculopathies. So there's a large group called motor neuron disease. Motor neuron disease includes ALS, primary lateral sclerosis, or PLS, primary muscular atrophy, progressive bulbar palsy, and pseudobulbar palsy. A few others include familial atrophy, lead poisoning. In unimmunized parts of the world, you want to look out for poliomyelitis. And I found it interesting that West Nile virus can cause a radiculopathy. Now we're going to take a look at polyneuropathies. So this is the second type of lower motor neuron lesion. The most common cause, diabetes mellitus. And so we always talk about how people can lose their foot or something with diabetes because they lose the feeling. Diabetes, so if you have this is the microvasculature, this is the vessel that blood is coming through, diabetes will cause damage to this and the nearby nerves that are traveling with it. In development, typically the nerves and the blood supply move together, and so they're always going to be nearby each other. If the blood supply gets damaged, then it's a really good chance that the nerves will also get damaged. I'm going to take a minute and just indicate everybody, I have a big chart in the study guide of a lot of the peripheral neuropathies and their specific patterns as well. So you can take a look at that, and that kind of help you narrow down a differential diagnosis. Guillain-Barré is another cause of peripheral neuropathy. I'm not going to go into that because I think that someone else is probably going to talk quite a bit about that. Then mechanical injury. There's something called Wallerian degeneration that can occur with mechanical injury. I'm not going to explain everything about it, but to say that in this specific type of injury, after a short amount of time, the nerve skeletal network can regrow, and the muscle weakness or even paralysis in some cases can go away. And in this specific type of degeneration, if it doesn't go away, some surgeries can help make it go away. So you can regain quite a bit of function from surgical procedures with Wallerian degeneration. There's infections. So infections can cause peripheral neuropathy, HIV, CMV, varicella zoster, hepatitis B, and Lyme disease. And that's just the more common ones. The list is larger than that. There's toxins. There's several toxins that can cause it. I didn't even take, like I said, there's a chart in the study guide. Look, it's nothing but the toxins that can cause peripheral neuropathy and their patterns. Then you have hereditary, two of the more common, Charcot-Marie-Tooth and amyloid polyneuropathy. Any type of chronic inflammatory demyelinating polyneuropathy will cause muscle weakness and possibly sensory loss. And then alcohol abuse can also cause polyneuropathy. Going back really quick to Guillain-Barré, just to make sure that the patterns are recognized, you're going to have, it's an acute inflammatory demyelinating polyneuropathy, and in this case, motor is greater than sensory in the deficit that's caused by it. It's progressive weakness, so we'll say progressive. It causes areflexia, so just your typical lower motor neuron lesion, areflexia, tingling paresthesia in the hands and feet, so the sock and glove. And then it's associated with a recent infection of the stomach, especially with Campylobacter jejuni. And so people that travel to specific places, and I think there was some specific country in Asia that had chronic exposure to Campylobacter, and people that travel there have a slightly increased risk of getting Campylobacter infection, and then from that, an increased risk of Guillain-Barré. Now here's a representative list of the much larger list that you're going to find in the study guide. Of course, we got the very common things listed, so diabetes being the most common, and what you're going to see. First, let me tell you what the letters mean. So A is acute, SA subacute, and then C is chronic. Then S meaning sensory, SM meaning sensory and motor, and M meaning motor. Then so you can see that, for example, in a sepsis, you're going to have motor being affected more than sensory. In a carcinoma, you're going to have sensory being affected more than motor. So because certain things are demyelinating in acute, subacute, or chronic, and certain things, for example, are not demyelinating at all, like a critical illness, then you can use EMGs to help identify the patterns and break down your differential further. Again, this representative list is taken from Up to Date. The full list is copied to my study guide. With a mononeuropathy, very, very simple. You look at the dermatome, you look at the myotome, and that should help you zero in very, very quickly on exactly what nerve is damaged or having a problem. Now, when I started this, I said we can talk about muscle weakness from the top down, starting from the upper motor neurons, the lower motor neurons, the neuromuscular junction, and the muscle itself. And before we go into the neuromuscular junction, specific diseases of it, I want to go through the basic anatomy and nomenclature. A motor neuron is a nerve that stimulates a muscle fiber. So it's a single nerve, and so we have this single square right here indicates this motor neuron. Then the motor unit, this single neuron with all of the myocytes that it stimulates. So you can see that the motor neuron, that the axon branches at its terminal end, and it stimulates multiple muscle fibers. So the nerve itself plus the muscle fibers indicates the motor unit. The expansion, I'm going to try to blow this up so you can see it. The expansion at the terminal end of the motor nerve is called the synaptic end bulb. Next we have the neuromuscular junction itself. It's a specialized single synapse between a motor neuron and a muscle cell. This is the most studied synapse, and so it's usually used as in didactic tools to teach what a synapse is and how synapses work. The motor end plate, that's the area where the naked end of this bulb is, the exposed portion of it is interacting with the sarcolemma. And so the motor end plate is specifically a portion of the sarcolemma where it's interacting with the nerve. And so just to bring this into big picture, right here we're looking at the entire neuromuscular junction, and then we zoom in at this little squared area and we're seeing that right here. So this is the sarcolemma, and the area, so that would be this entire area right here would be the motor end plate. The synaptic cleft, that's the space between the axon terminal and the muscle cell itself. So this empty space that we can see right here, this is all synaptic cleft. Next we have dense bars. Now dense bars is referring to something that you see only in electron microscopy, and so if you look over here, there's this area that has a denser look to it. These are the dense bars, and they're ACH-filled vesicles. That's where they're gathered. It's known as the active zone. And this is a protein-rich area, so it's got all the docking proteins and everything needed for these vesicles to do what they need to do. What you should notice is that these dense bars, these active zones, are nearby. They're nearby two things. They're nearby the calcium channels that for the presynaptic nerve, and they're also nearby the ACH receptors on the nearby motor end plate. So here's just another sort of simplified representative picture of the neuromuscular junction. Something I want to point out though, if you look over here, here's a Schwann, so I want to zoom in on this. So here we have this Schwann cell on the axon at the terminal end, and it's coming into contact basically with the muscle fiber. And so what's doing there, whenever the neurotransmitters are released from here, they get broken down into choline and acetate after they've interacted with the muscle. And that choline, we don't want it to escape, and so we want to reuptake as much of it into the nerve as possible so we can make more ACH. According to Costanza, there are 7 steps in the action that takes place at the neuromuscular junction. So here's Costanza's simplified view of the neuromuscular junction. Right here we have a picture of an ACH receptor. So this is a receptor where ACH will bind and cause it to open up so that sodium and potassium can flow through and flow towards their equilibrium potential. Over here is a more diagrammatic view of that same protein channel, and you'll notice that we have 2 alpha units. The alpha units are where ACH will bind to, and so it takes 2 molecules of ACH binding to this channel to cause it to completely open up. Now down here in the center of this protein core, we have charged amino acids, and what those charged amino acids do is 2 things. First of all, they allow any neutral substance to flow through, so water can move through. So this is a water-filled core. The other thing is they prevent negatively charged particles from flowing through, and they also prevent positively charged particles that exceed a certain size from flowing through. And that's at this area where the diameter is the lowest, or where those charged amino acids are. Now, Costanza says there are 7 steps to the events at the neuromuscular junction. I think there's an 8, so on Costanza's list, I'm going to add a step 0. So step 0 is the production or formation of ACH into vesicles. So step 1 is the presynaptic terminal of the motor neuron is brought to threshold. So right here we get this brought to threshold from the arrival of an action potential, and that causes calcium channels to open. So calcium hasn't moved in yet. The calcium channel just got brought open from the arrival of an action potential. That's step 1. Step 2, calcium flows in. Now, calcium is going to bind to 2 main proteins. One is synaptotagmins, and the other one is snare. Snare is a huge complex of proteins. So the synaptotagmins require an obligatory cofactor called complexin. So there's a lot of proteins going on here. So you got complexin required by the synaptotagmins. You got snare, or this huge snare protein complex. All this is going on. This is important because interference with this will cause problems with muscle weakness. So just think synaptotagmins and a big complex called snare. And that's where the calcium will bind to and it will cause a nanometer-sized movement that will dock these ACH vesicles and get them ready to eject. So that's step 3. Step 3 is the ejection of the neurotransmitter from calcium. So the synaptotagmins, the snare. Now there's some of the subproteins in snare that you need to be familiar with is syntaxin and synaptobrevin and SNAP25. So I'll just write those down. So snare, you have syntaxin, synaptobrevin, and SNAP25. And if I remember right, these are the proteins that the black widow venom interact with. But I have it on the next couple of slides coming up. Next thing that happens is that ACH moves across the synaptic cleft and bind to, on 2 different spots, bind to the ACH receptor, often abbreviated as ACH capital R. As I already explained, this is permeable to very small positive charged ions as well as water, so those being sodium and potassium. They can flow in and out. Now, potassium is going to move down its electrical chemical gradient. Sodium is going to move down its electrochemical gradient. So in step 5, that's what step 5 is. Step 5 is the movement of sodium and potassium down their gradient. Now, in a simplified view, we're saying that this muscle fiber is only permeable right now to sodium and potassium. And if that were true, these could keep moving down their potential, and the muscle fiber would go from negative 90 millivolts to 0 millivolts. But it's actually permeable to several other things. So the lowest you're going to get that at this particular spot is negative 50. So something called the end plate potential is negative 50 millivolts. So since I brought up the end plate potential, or EPP, it's important now to bring up something called the miniature end plate potential, or MEPP. So the miniature end plate potential is something that happens whenever a single vesicle of acetylcholine is released. Whenever a single vesicle of acetylcholine is released, it will act on the muscle surface and cause a depolarization of positive 0.4 millivolts. And because each vesicle of acetylcholine will bring about 0.4 millivolts, vesicles of acetylcholine is said to be quantal. So there's a quantum of acetylcholine, and that quantum of acetylcholine will depolarize by 0.4 millivolts. Because of that, because we have to go from negative 90 to negative 50, we have to go 40 millivolts, which means it would take 100 vesicles to bring about the end plate potential. A minimum of 100 vesicles of acetylcholine have to be released across the synaptic cleft in order to bring about an end plate potential. So that is step 5. Step 5 being the sodium and potassium flow down their concentration gradients, bringing about an end plate potential of -50. Now step 6. Step 6, a motor end plate cannot fire an action potential. So this motor end plate cannot fire an action potential. So what will happen is that the depolarization of the end plate potential will spread, and whenever it spreads sufficiently, it will initiate the action potential over at the normal muscle tissue. So firing of the action potential in the muscles is step 6. Now, in the final step, step 7, acetylcholinesterase will break down acetylcholine into choline and acetate. The choline is then retaken into the presynaptic neuron through a sodium choline cotransporter. So if you have a problem at any step along the way of the 7 steps, or if you count step 0, the 8 steps in what takes place at the neuromuscular junction, you can get motor weakness. And so, for example, step 1 and 2 are affected by something called Lambert-Eaton, which is myasthenic syndrome. So what happens with that is the antibodies are produced during during a cancer, usually with a lung cancer. Antibodies are produced that will interfere with these calcium channels. So if they can't open, you got a problem with the step 1, and if calcium can't move in because it's blocked, you got a problem with step 2. It's important to note that calcium channels are being made and remade and reproduced all the time, and it's also important to note that in Lambert-Eaton, not all of the calcium channels are going to be affected. So some of the calcium channels, the very few calcium channels, will cause some acetylcholine to be released, but not enough to cause end plate potential. So if you keep stimulating those few calcium channels over and over again through, like say, successively squeezing your hand, then what you'll get is you'll get progressive increase in strength. So that's one of the tests for Lambert-Eaton. Step 3 is inhibited by botulinum toxins and with alpha letrotoxins. With alpha letrotoxins, the black widow venom. So botulinum toxin is going to interfere with the docking proteins, and the black widow venom is going to specifically interfere with the neurexin. Neurexin is not only it is important for the exocytosis of acetylcholine, but also has another function of holding the terminal axon onto the motor end plate. So there's just to point out, there's more than one action or activity going on with neurexin. With other things like plant toxin known as curare, it's going to bind with and block alpha receptors. I'm not sure how my picture got squeezed like it is, but if you remember that the receptors on this on the muscle fiber is going to have 2 alpha receptors, and so those alpha receptors they bind with acetylcholine, and if they can't bind acetylcholine, they can't open and allow sodium and potassium to move in, and so that's what happens with curare. And succinylcholine is a derivative that was made. It was a derivative of curare that was made in a lab. Myasthenia gravis, it's going to have antibodies that have an epitope the epitope will also bind with these alpha receptors, just nanometers. So nanometers away from where acetylcholine is supposed to bind, you'll have an antibody binding. So it doesn't completely stop acetylcholine from binding, but it inhibits it extremely. And the other thing that it does is it will cause the increased endocytosis of those receptors, so the half-life of the receptor is decreased. So what do you do to treat that? Well, you increase the amount of acetylcholine out here, and the fewer receptors that are available get stimulated more and more, and they can produce an end plate potential after they've been stimulated several times. So the way you get acetylcholine built up in the synaptic cleft is you inhibit the acetylcholinesterases. There's 2 things that can do that. An acetylcholinesterase inhibitor, which is a medication that can be given, or you can do what's called the ice pack test, So if you have myasthenia gravis, especially with ptosis, drooping of the eyes, you can put ice over their eyes, and if the drooping improves after a short time with the ice, that's indicative of myasthenia gravis. And what's going on there is the ice is slowing down the acetylcholinesterase activity, and so you get a buildup of acetylcholine in the synaptic cleft. There's a problem with this, though. It's called cholinergic crisis. It's where the receptors get desensitized. They've been overstimulated way too many times, and so they become desensitized. And whenever that happens, you have to stop acetylcholinesterase inhibitors, and you have to just monitor the patient, make sure they don't die, make sure that they don't stop breathing until their receptors can become resensitized again. Step 5 is the actual movement of the ions through the channel. Now, alcohol and lidocaine both have the ability to bind within the pore of these sodium-potassium ligand-gated ion channels. And so what they do is just bind in there and block it. I know whenever you're drinking, you might feel like you're 50 feet tall and bulletproof, but you're actually just really weak and can't do crap. I wouldn't know, but you guys might. With step 7 and step 0, there's a drug called hemocholinium. This drug is only used for research. It has no known use outside of research on animals. And what it does is it blocks the reuptake of choline, preventing the resynthesis of the ACH. So as the choline gets brought back into the cell, typically, if you can stop that, you can stop the resynthesis, step 0 of ACH synthesis. And then finally, there's something called myopathies. So myopathies are when the problem is with the muscle itself, and that's things like muscular dystrophy, polymyositis, HIV we talked about with peripheral neuropathy. It can also cause myopathy. You can have malignancies, something called malignancy-associated myositis. Steroids, don't ask me how that works because I thought steroids made you huge. Hypothyroid, hypoglycemia, hypokalemia, or low potassium. The idea with low potassium is that if we imagine this is our muscle cell with potassium inside of it, if you have a very, very low concentration of potassium outside, then it increases the gap. So if the normal potassium gap inside and outside is this, then this is the strength by which potassium wants to move out. But if you increase that gap, then potassium wants to move out much more, and so it will move out what's called a leak channel. The leak channels will allow some conductance of potassium in and out of, or out to flow out of the cell. If you increase the difference or the chemical gradient, then potassium will have a much greater moving out of the cell, and that will cause a hyperpolarization. So instead of that muscle being at negative 90, it could be at negative, 95, so to speak. And that means it's going to take a much stronger impulse to bring the muscle to threshold and cause it to fire. The important thing to note with hypokalemia is that potassium is used in every kind of muscle cell, not just skeletal muscles. So you're going to have heart problems as well, like flutters and all kinds of things with the heart. And so if you're seeing weakness and you're seeing problems in cardiac tissues and that kind of thing, then and your blood chemistry says low potassium, then you're going to look at that kind of a little bit stronger. All right, this is the page that you're never going to look at again, so I don't even know why I try. I'll just flip it upside down. You'll have to pause it at the beginning of that slide to see it.